Gola Center for Health Policy, welcoming you to today's Accountable Care Learning Collaborative webinar on accountable care communities integrating medical and social services. We've got a lot of ground to cover today, and it's a very rich and timely topic, one with a lot of potential. So I want to get right to that, but let me start with just a few housekeeping items first. I think you all should have started out with your lines muted through the GoToMeeting system. But if you are dialed in, please make sure that your phone is muted so we don't hear any background noise. Please don't put us on hold. You can always call back in if you need to sign off for a little while. If you are, in order to mute, you can use your phone mute button if you're on your phone, or your computer if you're logged into the webinar that way. Use the microphone icon. Please do make sure that you're muted. We are going to have a number of opportunities for questions, or a major opportunity towards the end of this presentation. If you do have any questions for us, please email us at the Accountable Care Learning Collaborative, or use the chat feature of the GoToMeeting window if you guys are logged in online. So that's the chat feature that should be coming up along with the login to the webinar. As I said, and as you see on the next slide, we have a lot of ground to cover today. We're first going to briefly review some recent developments at CMS around the accountable care organization-related programs, including the recently released updated benchmarking methodology for the Medicare Shared Savings Program, and the recent announcement from CMS in a collaboration with AHIP and many other organizations around alignment on multi-payer quality measures for accountable care. Then we're very pleased to have two terrific guests with us today. First will be Dr. Steve Shortell, who I'll introduce in a little bit more detail in a few moments. For those of you who don't know him already, has been one of the leaders in accountable care organization implementation, and lately has been particularly focused in doing some path-breaking work on understanding and the best ways to support and implement accountable health communities, again, our major topic for today. And then we're going to hear from someone who's been at the forefront of actually doing this, Julie Bluhm from Hennepin Health. Finally, we want to turn to the CMS Accountable Health Communities model. This was also announced recently with some proposal deadlines coming up soon, and we think that's going to make more sense to talk about after you've heard about the context for accountable health communities in a bit more detail. And then we'll have a bit of time for discussion at the end. Again, use the chat button at any time, or send us a question by email via members@accountablecarelc.org. So let me turn to the couple of CMS updates. I'm going to go through these briefly in the interest of time, but want to remind you that there are additional resources related to these announcements on the ACLC website, including more detailed papers and an executive summary of the benchmarking proposal. The benchmarking methodology, which is, you'll see a kind of overview of this announcement on the next page, describes some significant changes in the methodology for measuring an ACO's financial performance in the Medicare Shared Savings Program. This has been a while in coming. It's something that, for those of you who were with us last year, my FOM talked about in our previous meetings as being a priority for the agency, but getting these things through clearance and confidence that they're going to lead to positive budgetary effects, well, that takes a while, but it is out now. And the main thrust of this shift in benchmarking methodology is to enable a transition from ACOs participating in Medicare being graded against their historical performance and towards being subject to a benchmark that depends on how well they're doing relative to care costs in their region. So ACOs still start out in the Medicare Shared Savings Program in the first 3 years based on their historic benchmark, so quite similar to what has been the baseline benchmark methodology. But after that, there's a transition to a benchmark that increases the weight on regional spending. And CMS accompanied this with a new option for some of the ACOs that may have been thinking that without this kind of shift, they would have to stay in track 1, the so-called upside-only risk, giving them a new option, even though many of them are now in year 4 of the program, the second performance period, the second so-called 3-year performance period. They have a chance this year to shift over to tracks 2 or 3, something that CMS hopes that the added clarity and confidence of this switch would make possible. The next slide talks about some of the specific modifications. I'm going to let you all read through these either now or at your leisure, and again, it's covered in more detail on our website summary of the proposal. But the main thing is to enable ACOs that are performing better or improve performance over time to have confidence that their baseline isn't going to keep shifting down as their performance improves, that if they are actually performing better over time relative to others in the region, that they'll be graded on that scale. You might ask, well, why not do that right away? I think the main reason is for a voluntary program like this one, CMS and their actuaries and the budget experts at the Office of Management Budget had a couple of concerns. One is they wanted to have confidence that the organizations that were taking advantage of this program over the long term really were ones that were, likely to succeed and had shown a track record and had demonstrated a real commitment to the program and not just getting in it to see what happens. And second, related to that was, I think, a concern that if the benchmark started based on regional performance right away, many organizations might take a look at the benchmark relative to their current costs and just decide, hey, if my performance now is relatively low cost compared to the region, I should just get in this program and get some additional automatic, in effect, shared savings. And while that might be a fair thing to do for organizations that are less costly, you can see why from a budgetary standpoint, since that would mean more Medicare spending without any real changes in further changes in practice happening, why there might be some concerns with that from a budgetary impact standpoint. So this is meant to be a clear transition pathway, basically that if you show that you can stick with the program and perform reasonably well in it, over time you get to move to a regional benchmark where you're graded not against how you did historically, but against the benchmark performance in the region. Let me go on now to, to talk about the recently announced collaborative effort around multi-payer quality measures. I've worked with a number of you in the context of the Healthcare Payment Learning and Action Network. As you know, there are a lot of efforts underway now, including collaborations through the ACLC to try to get to better identification and implementation of best practices in payment reform and reducing the costs or the barriers to implementing effective payment reforms. And one of the main areas of focus or concern around potentially avoidable burdens for shifting to these new payment models has been lack of alignment of performance measures. There have been a number of reports in recent years highlighting that while in the case of ACOs, many different payers are aiming for the same types of performance measures, say around better patient experience and better control of chronic diseases, better use of preventive services, the exact measures don't always match up, and that's the perception, and I think to a considerable extent the reality has been that is an administrative burden on providers that are trying to move into these new payment systems, and also may undermine the effectiveness of the reform. So it's not to say that we've got everything figured out perfectly in new accountable care payment methods, but where there are some well-established best practices and where it seems fairly clear that minor but administratively cumbersome differences across performance measures really aren't worth the additional individualization, moving towards more aligned in practice payment measures could be beneficial. And the goal of this collaborative that started out between CMS and a number of the payers, insurers, and private insurers and AHIP and has since been expanded to include a broader range of collaborators, including purchasers, including consumer groups, including a closer collaboration with the Healthcare Payment Learning and Action Network. The goal of that was to get to some very practical and specific measures. So as you can see on this slide, this collaborative effort was intended to inform the further work in Medicare's use of performance measures, but the expectation is that with Medicare moving in this direction and a process that has included private payers and other stakeholders as well, it'll be relatively easy for multiple payers to align on the same consistent core measures. We're focusing here on ACO measures, but I would emphasize that actually core measure sets were released in, I believe, 7 different areas, not only including ACOs, but primary care and patient-centered medical homes, cardiology, gastroenterology, HIV and Hep C, oncology, OBGYN, and orthopedics. Those additional information on these measures is available, again, through the ACLC website, and I would expect to see, to the extent that CMS has not fully embraced these core measures yet, we expect to see that taking place in the near term and CMS's forthcoming regulations that govern the specific performance measures used, and also there's a strong commitment from many of the private payers to move to these same core measures as well. Finally, if you take a look at the list of these measures, you'll see that they have some substance to them. They're important measures in areas like, say, hemoglobin A1C control or use of preventive services that are part of core measure sets right now, of ACO measure sets right now. But I think everybody involved in this collaborative realizes that the measures need to get better. For example, the list of available measures that could readily be adopted widely for things like patient reported outcomes or functional status, things that clinical outcomes that matter a lot to patients. We just don't have those measures in widespread use yet. So view this as a core set, not a final set, but one that is intended to help get alignment on a basic set of measures and enable, therefore, more progress, more focus on developing better measures for the future. And we'll keep you informed about those steps as well. So that's a little bit of a quick policy update. Let me turn right now to our main topic on accountable health communities by introducing, I think, the nation's leading authority in this area, Dr. Steve Shortell, who's the Blue Cross of California Distinguished Professor of Health Policy and Management at the School of Public Health at UC-Berkeley, where he also directs the Center for Healthcare Organizational and Innovation Research there. Steve has done a lot of the path-breaking work on understanding the different types of accountable care organization arrangements that exist and which features of ACOs seem to be associated with more or less success and different kinds of implementation settings. He's recently turned a lot of the effort for his organization and collaborators to this very important notion of accountable health communities, going beyond ACOs per se and into interventions and collaborations that could be sustainable at the community level, and through that mechanism can have an even bigger impact on public health and limiting healthcare costs. So, Steve, let me turn to you to help set up what we mean by accountable health communities, and then talk a bit about them for this webinar.
Very good, Mark. Thanks for that, and hello, everyone. And what I'm going to do is go through about 8 slides that you'll see here and kind of introduce the topic, put a little bit of flesh on the bone, but really set it up also for Julie Bluhm at Hennepin, because they're a great example on the ground, as many of you are in the trenches there trying to make some of these changes work in your communities. So I want to begin, as you see there, just with this definition of accountable community for health or accountable health community. It goes by different names and acronyms, but the important notion is it really is about population health writ wide. As we all know, population health management, that term is often used within an ACO or risk-based contract of some sort to refer to the enrollees in your health plan or the people in your health system that you're actually managing. And yes, that is population health management, but it just refers to the people getting care from your system or from your practice. Accountable Communities for Health goes way beyond that and actually looks at the health of an entire community, a geographic area. And therefore, as we all know, what produces health is about 80% our environment, the social conditions, et cetera, behavior things, and maybe 15-20% what the healthcare system is able to do. So the definition, as you see there, is it's really a multi-sector, multi-payer alliance that will involve health systems, of course, and providers, but also key community and social service organizations, which we'll talk about, schools and so forth, and improving the health of the entire community, and in particular, in our country, the gaps that we have in terms of equity given the diversity of our country. So this is the basic definition that I think most people are working from. Now you can break that down, as we do in the next slide, to the essential functions. And these are things you want to start thinking about in terms of developing readiness assessment for the capabilities in our communities, in your communities, to be able to do some of this. So the ability to convene a broad set of stakeholders, not only from the health sector, but housing and transportation, education, public health, and so forth, community development organizations. The ability then to get a shared vision and goals among all those parties. And a related concept here comes out of some of the organizational research literature is relational coordination, that actually asks you to look at 7 items in terms of as you try to bring partnerships together. One is, yes, shared goals, but also shared knowledge. Is everybody sort of on a common knowledge base that you can talk to one another in a common language? And then mutual respect, of course, is important. And then communication. Is it frequent enough, timely enough? Is it really specific enough, and is it problem focused? These are some elements that need to be in place. Community health needs assessments, obviously working on the data from those. Assessing community assets. This grows out of some work by John McKnight and others. All communities have problems wherever we are. We can talk about our liabilities, but also to do an asset mapping. We also have strengths, and to go with those strengths mapped against the opportunities. And so this is an important element. Developing a backbone integrator organization. And again, Julie will cover this. Hennepin County has that. This is the organization that's going to kind of be the glue that pulls the different sectors together and manages the budget and the resources in order to get the work done. And then the final bullet is something we've got a small grant here in California to work on, and that's to create the information systems to measure performance, the management, continuous improvement, and accountability. We all know how difficult it is in the healthcare sector in terms of interoperability challenges just to get information that can follow patients within the healthcare system. But this is asking to go beyond that and say, well, what's the relevant information from the housing sector or the transportation sector or the health department that we need to have in order to manage population health community-wide? So it's a huge challenge that we don't pretend to have a lot of answers for at this time, but we're trying to find out as fast as we can. And then the next slide gets around to, well, how's all this going to be financed, right? I mean, it's nice to talk about this. It sounds good on paper, but where the rubber meets the road, where are the resources going to come from? And in the paper, we give a reference here to my colleagues, Elliot Fisher and Janet Corrigan. They, in the paper, identified and pulled together a lot of these different sources. So you have community benefit funds, for example, that can go towards this. Some areas, some payers might experiment with regional global payment. So in essence, you take a community and you say this isn't just a risk-bearing contract for the health system in that community to take care of diabetic patients, but we're going to give you a budget to this backbone organization. And you look at diabetes in your whole community, not just that one health system, and see what you can do to reduce the pre-diabetics, for example, as well as readmissions for diabetics and admissions to begin with, and so forth, and see what you can do about obesity rates in children, etc. And we'll give you sort of a global budget to manage diabetes care and prevent diabetes. And if you can do that through whatever behaviors and partnerships you form, you share the savings and you decide how much is going to go to the health system, how much is going to go to the transportation agency or to the school system. So that's a little bit of outside the box, but that's an example of regional global payment. ACO shared savings, the shared savings that Mark mentioned that some ACOs are achieving, there's a lot of things you can do with it. You can put it inside your own organization, pay it to the doctors, pay it to improve your electronic health records, but if you're a part and want to play a leading role in one of these accountable communities for health, you might also target some of those savings towards that population community-wide investment. So that could be a source. Health and Wellness Trust, social investing. Fresno Asthma Project has a number of social investors here in California in which they hope over time to get a return on that, but it's also a way of supporting some of what they see is going to benefit the entire community there. It's the Fresno Asthma Project. If you're interested, we can get you more material on that. And then one of the things we did do here in California last year is we were asked by a local foundation to come up with a white paper to give to groups here in California that are going to apply in the next few months to become an accountable community for health. We have some local foundations and Kaiser Permanente in the state putting in some money, and they're going to fund up to 6 of these. Modest funding for sure, but they wanted something that where do you start? Where might the payoff be? And what's the evidence base for various forms of intervention? So we developed this kind of typology of different levels of interventions that the accountable community for health could do: clinical community linkages, systems and policy interventions, and environmental. And on the next slide, what you'll see is a summary table of kind of what we mean and what we found. We did this between 2004, roughly, 2005, and 2015, and we looked at about 2,000 or so in the literature, the peer-reviewed literature, and boiled it down to 155 studies. I had a number of doctoral students do this that met sort of a gold standard in terms of criteria for including them. And so some of these are single interventions on the left, or a portfolio. They addressed more than one condition or used multiple approaches. And you can see examples under the clinical, and the numbers in parentheses are the number of interventions we found. So some were directly just clinical, medical homes, for example, disease management programs, also for this community intervention and drawing on more community-wide efforts, YMCAs and so forth, exercise programs, nutrition, lifestyle, and so on. Some then were linkages between the two, putting pharmacists on the care team. And I think some people believe pharmacists are going to play an increasingly role in all of this, telephone-based support. And then we have examples of policy, system policy, environmental interventions around the built environment, governmental policies, zoning laws, things of that sort, and community collaboratives, which I'm sure Julie will talk about in terms of what's going on in the Twin Cities. And then the next slide just brings it down to a specific level around asthma conditions. And Boston is doing some very interesting work in that area, Boston Children. And we just show in there the criteria that one can use. So what is it they're doing? Multidisciplinary, it's community-based, trying to prevent costly complications and hospitalizations. The time frame here is by when they thought they would be able to move the needle and have some data on improvements. And so this was a 1 to 3 years. Not all of this takes 5 or 6 years. Some of it does, but some you get a more immediate potential payback. They have found reduced ED visits and improved quality of life. They were able to calculate a return on investment. Off the top of my head, I forget what the numbers were, but it was significant. We also tried to assess how easy it would be for an ACH to implement in terms of bringing people together and the pervasiveness of the change involved. This was intermediate, and you see the indicators of success. This article and this intervention did not report in detail the kinds of data needed. And then on the next slide, we just provide an example of cardiovascular disease. And here the intervention was physical activity and weight loss. And you can see the description. Again, they hope to be able to see some evidence in 1 to 3 years. You see the outcomes there. They were not able, or at this point in time, to calculate an ROI. This ease of implementation was pretty easy for them to do some of this. And again, you see the indicators of success. So if you're interested, we can send you the entire report. It's not published. It's a white paper. It's on the website of the California Department of Health. And we do this that you see here for about probably another 16 or 17 interventions as examples. So let me move then and kind of summarize before Mark will turn it over to Julie, and kind of say that what we found through this exercise, and this is being drawn on now by potential applicants here in California to become accountable community for health, the strongest evidence base were really these single focus, easier to implement short-term interventions. And I'm not saying necessarily that's the only way to go, but this is what we found, and they would target very specific clinical or clinical community linkages. Second thing we found is the strength of evidence for where you want to put your resources was highest for the diabetes interventions, about 4 out of 5 there. It was least frequent among asthma interventions. That was about 50% of what we found there. The most common interventions were lifestyle, behavioral, also pharmacists on the care team, use of community health workers that could work across the health system to the school, to the social service agency, and so on, and also patient and caregiver education. And finally, we found that the multi-component strategies typically involve primary care efforts and then exercise, community collaboratives, innovative use of nurse care managers, and school-based initiatives. So these are some of the bullets from some of this work. And again, it is on the California Department of Public Health website, but we can also make it available to you. So I'm going to turn back now to Mark to introduce Julie.
Thanks, Steve, for that very concise summary of a lot of evidence and work. It's kind of interesting that, as I think was found with some of the early ACO successes, having a clear and focused, if not long, in fact, short list of key interventions to focus on with a clear plan for payoff is a good path to success. It'll be interesting to hear from Julie how her experience compares to that. So we've talked about the accountable health community goals, but as with many things in healthcare, the really hard part is not just describing where we need to go and some steps that could help get there, but actually doing it. That's the really hard part. And very pleased to have with us Julie Bluhm, the clinical operations manager at Hennepin Health, who has been doing this. So Hennepin, for those who aren't familiar with it, Hennepin County has implemented a number of specific regional level interventions that focus directly on the major determinants of health, which for many vulnerable populations especially is not health care, and they've got a great track record to describe based on that experience. So Julie, let me turn this over to you.
Thank you so much. I'm so glad to be here. You get the first slide, please. So Hennepin Health is a, as previously mentioned, an accountable care organization made up of 4 county-owned partners. I think Hennepin County clinicians and administrators realized a number of years ago that we had all 4 components or major components to make up an ACO. We do have a county-owned safety net hospital, which is called Hennepin County Medical Center. They own a hospital with ED and inpatient and specialists downtown Minneapolis, but then also have 9 primary care clinics throughout Hennepin County, so a pretty big footprint clinically. Our second partner is North Point Health and Wellness Center, which is a federally qualified health center in North Minneapolis, which is an underserved area of our community that has been doing integrated care in North Minneapolis for over 35 years. Our Human Services Public Health Department in Hennepin County is a very key partner as far as addressing social determinants of health. And then I think, so as I say, each one is very important and key. They are. But for our financial arrangements, we had this very good fortune of having a county-owned health plan called Metropolitan Health Plan, or MHP. And so we were able to work out an arrangement through our state Medicaid agency for a full capitated reimbursement through enrollment in our managed care, which is a choice for individuals for the past 4 years has been a choice for individuals in the Medicaid expansion population, so single adults without dependent children who are not disabled. And just recently, starting 1/1/16, we have added the entire families and children Medicaid population, which we're very excited about. So really in this system, it's about having a defined provider network, and so our members do go just to the clinical partners, and then we have a small expanded network to just kind of meet some of the needs for cultural diversity, including some of the local FQHCs. Also shared electronic health record, which I'll talk a little bit more about, but we're able to do some data sharing between the 4 partners, which has been really key. And really, I think the biggest thing for us was being able to align the finances between the 4 partners. So we realized that, in order to keep the hospital open, we need to have emergency room visits and inpatient income, but at the same time as being owned by the county and running a human services public health department, we had a lot of employees that were working very hard to keep people out of those acute care settings. And so this financial model really allowed us to align those incentives and work towards the same goals. Next slide, please. So as I said, a lot of our members are in the Medicaid expansion population, and what that means in Minnesota and Hennepin County is that we have a lot of people who have common overlapping issues such as multiple mental health conditions, chemical dependency. We have a large portion of our population that is unstably housed or homeless, and chronic physical conditions, of course, and then a lack of social support really defines our population. So when we talk about social determinants of health, our population is truly, I think, impacted in a very large way by these other factors that we talk about that impact health, that Steve talked about too. So knowing that, and this slide, if we kind of start over on the right and look at the factors that we know that impact health that go beyond the healthcare delivery site or what we normally think of as healthcare. And so we're really looking at how this model can impact social and economic factors as health behaviors, and then the built environment that people are coming from. So what we've really done in our care model is looking at how we can do increased care coordination within the healthcare setting. So we do have, our model is very much based on a primary care medical home model with strong community health worker roles, both inside and outside of the clinic. Initially, towards the beginning of Hennepin Health, we were very active in the support of what we call affectionately an ambulatory ICU model. So it's called the Coordinated Care Center, and they operate out of our hospital setting. And it is a team-based care model for the highest utilizers of our system. And so really doing a wraparound service for those individuals. In addition to the primary care medical home, we're supplementing this clinic care coordination with targeted behavioral health and social service interventions that are more sort of on the community side of, so we say care coordination within the community or outside of the clinics, kind of married to the care coordination within the healthcare setting. And we are just able to have a very kind of rich partnership of resources due to our structure and having the Human Services Public Health Department as a part of our risk-sharing model. So the tools that we use, like I said before, the shared medical record is key, so we're all using the same EPIC record. It's been very exciting to be able to share the EPIC record with the social service teams in the Human Services Public Health area. It's been a key to our success, I would say, in the last 4 years that we've been working on this initiative, that we definitely realize that if it's not, we say if it's not an EPIC, it doesn't exist. So we found that having the case managers, public health clinics, we have a social service navigation team that works exclusively with Hennepin Health. Being able to access and demonstrate their work within the EPIC record has just been key to integrating those social services into the medical home. We've done a lot of work on shared standard work. key to this initiative has been just building relationships. And I say just, but it's not that easy, it's hard. So building those team relationships with the staff that are already very busy working with the clients that they see in the clinics and also outside in the community. But we've realized that by incorporating the team members in their sort of going into each other's case consultation or huddle time and being able to talk about the cases together, as well as communicating through the medical record, has been really important in developing that sense of team across sites and across our partnership. Additionally, we have developed a prospective risk tiering mechanism in EPIC that is automated. And so essentially what we're doing is looking at targeting specific individuals based upon their risk for future costs with the care coordination resources so that we can really make sure that we are allocating our resources as best we can for a good return. Also, we look a lot at outcomes measurements in measuring our work. Next slide, please. So one of the initial, I guess the main initial premise within Hennepin Health is that if we don't meet our members' basic needs first, then we really aren't going to be able to meaningfully impact their health. And we knew that the population that we were serving was going to be, as I said, a lot were unstably housed. We ended up as the default Medicaid managed care organization for this population within our downtown area and North Minneapolis zip codes. And so what ended up happening is that, so essentially when someone signs up for Medicaid and they become eligible, our eligibility services send a packet in the mail and says, okay, now it's time to choose a health plan. And individuals have to choose their health plan based upon, their provider guides and just kind of, the researches they're willing or able to do about the health plan. And if you don't, and then return it in the mail, and you're signed up for a health plan. What we found is that many of our members default because they don't have addresses in which to receive mail. And so we did have a lot higher number of individuals that are, we've estimated, unstably housed, up to 50% of the people that we serve. And so including in unstably housed individuals who are homeless and officially homeless, according to HUD definitions, but more often people who are couch surfing or staying with relatives, staying in shelter. But we found a lot of people that are having just very kind of precarious arrangements for housing that really aren't conducive to taking care of their health. So very early on, we decided that we knew that housing was going to be key and a really important part of this intervention. And we were excited because the Human Services Public Health Department here at Hennepin County includes a housing and homeless initiatives area that manages all of the contracts for our providers in Hennepin County of what's known as in the Housing First model. And so we were able to use some of those contracts with providers to just meet with providers and talk about our initiative and ask if they would commit to prioritizing Hennepin Health members in their supportive housing. And what we were able to do then is work with our staff who were in the clinics using what we call housing navigators that were available to those staff in the clinics, and ask them to identify medically complex Hennepin Health members who were unstably housed or homeless and whose housing was directly impacting their health. And so really looking at people who had one or more chronic conditions, as I said, were homeless, and then we could say, we're really having a big impact because of their homelessness. So what we were able to do over the first year and a half of Hennepin Health is we housed 123 people that we were able to look at as a pre and post. And we pulled initially the six-month results after housing, and we found a significant decrease in both ED visits and then inpatient admissions, which we were really excited about. We're able to pull those numbers again in 12 months, and the results that we came up with are in front of you on a slide. And so essentially, what we found is that when people are housed, And I don't think this surprises anyone, and I think it's quite validating and reaffirming for our colleagues in the housing world that that yes, housing doesn't in fact impact health and does in fact also decrease costs across the board, looking at unneeded ED and inpatients. So we're really excited about this. So that's just one example of ways that we're able to use this really unique structure and financial model to do something a little bit beyond, or a lot beyond, what a normal managed care organization could do. Next slide. So I was asked to talk about challenges, and there are many. We've been at this for, as I said, about 4 years, and we really started this from the ground up. And these 4 organizations, as much as we, yes, are all owned by one entity, the silos are pretty high. And so I'd say the first one is just that collaborative initiatives are always really hard. The work that we're doing to collaborate is beyond our day jobs. And when we're talking about beyond the day jobs of medical providers, that's pretty overwhelming. And I think it's really difficult to get people to commit to doing extra things outside of their regular job. And we've found that to be true, I think, in this project. So advice around that is we've found that leadership buy-in from the beginning is just essential. When working across organizations as we are, it's really important that the individuals who are involved in this collaborative directly and involved in making decisions and on committees have clear roles and expectations, and that they're hearing it from their leaders that their involvement is important and that they're being held to goals related to that initiative. So as much as you can, I put operational authority where possible. We don't have much. We've got our structure is pretty matrix and consensus driven, and that has been a challenge. I think it's really difficult to keep line staff and management staff engaged when they're really not seeing they're not being told that this is a big part of their outcomes, or not being the goals aren't being driven from above. And so that's definitely been something that we've had to really kind of work on building out. The second thing is that the safety net culture we found is very uncomfortable serving some and not all, and that makes a lot of sense. And so because Hennepin Health is a pilot and because it's operating as a managed care organization, the folks at our healthcare providers at HCMC and at Northpoint and in our public health system are serving a lot more people than just the Hennepin Health individuals. And what we found is that this model we have resonates a lot with the providers and a lot with staff, and they really do, just from a gut level, feel like this is the way we should be providing care. And so starting out and saying, well, we don't know if this is going to be better or not, so we're going to pilot with this population, didn't fly very well with them. And there was just a lot of discomfort, and still is a lot of discomfort, around just providing this level of service integration to one group of people and not the other. I'd say that the way that we've moved is that really we are, as we gain knowledge and we're working together better and the team is built across these 4 partners, there's no way it's not impacting people that are not in our Hennepin Health model. It's impacting the way that we do our job. And so I think we're seeing that, and this is moving on. But I would definitely address that if you were starting in a safety net culture. We're finding that we have to, because the resources are so limited, as much as we'd like to be able to give the social interventions to everybody that we see who has social complexity, we really found that we have to target them very specifically. As it says, we can't realistically solve all social issues with just healthcare resources, and that's true. And so we've really had to work, it's not really I'm a social worker by training, and it's not really in our social work blood or in our provider blood to want to not give all services, again, to all people. But we found that we really are able to give more people more by accruing savings and allocating it in other areas that can impact the system as a whole. And in order to do that, we have to really provide these very specific, intentional interventions to certain people. As we've moved into, and this, I absolutely agree with Steve's observation and what the evidence is showing, that we really want to have the specific interventions on a smaller scale are probably more effective, and we spread ourselves pretty thin here. We've gotten a lot of projects up and running. We've gotten a lot of different components to the care model, and more as we try to look at pre-post costs based upon an intervention, we say, none of this is happening in a vacuum. And so it's really hard to know, was it the housing or the care coordinator who were working together that made the big difference? And so I think that it's really hard to just continually add things and then try to evaluate them as one intervention. And so we've had a really hard time figuring out how to model our evaluation difference so that we can sort of determine, is this intervention, an effective piece of our care model versus something else. So that's definitely been a challenge. And then finally, we're learning. So we're new. We're, a small project, I guess, in Hennepin County that has only been around 4 years, as I keep saying. And a lot of these things, the investments take a lot of years before we really are going to see a return. And I think that the excitement towards ACOs and the way that our health system is developing towards accountable care and paying for performance, I think sometimes is a mismatch. I think we're learning more and more that sometimes we just kind of have to close our eyes and trust that, if our staff and our clinicians and our administrators are saying that these things really work and they're really providing better care to their patients because of the integration, that maybe we're not going to be able to quantify it into savings right away, and we may not be able to see it, but we can sometimes trust that sense because all of our experiences are, our data, and I think trusting what we know and what appears to be working is something that we've had to start to do more. I think when we started, it was all about analytics and data, and we're starting to realize that, if the staff are saying this is really helping and this is making a big difference, then that's pretty valuable too. So that's what I've got. I'm willing to, we do have a website, hennepinhealth.org, so if you're interested, we have monthly newsletters, videos, and more information.
Julie, thanks very much for excellent presentation, a very concise one as well. We do have a few minutes for questions coming up shortly here, and encourage you to send them in via the chat box or the email address that I gave you earlier, and that's in the slide deck. We've got some good ones already. Before we turn to that, though, we wanted to put these kinds of steps in the context of a very recent CMS announcement this past month about accountable health communities, and this is a high priority area for CMMI. It kind of rounds out, I think, the major set of payment reform initiatives that this administration is trying so hard to implement. So some recent steps in bundled payments and episode-based payments that we've talked about. We've talked about kind of the steps to help solidify the Medicare ACO programs. This recent announcement is not the only thing that CMMI has announced related to population health improvement. There have been some earlier efforts as well as efforts through states, but it is kind of the big one. The CMS has an office headed up by Dr. Darshak Sanghavi, who used to work with us in my former group at the Brookings Institution, and very much shares the commitment to aligning payments with the goal of better health. And this is, again, the CMS effort to really tie it to the importance of social factors and community factors, like Julie was just describing, to enable progress over time in getting there. So I'm going to talk briefly about an overview of this program, basically I already have, and then Steve Shortell is going to provide a few more details before we go to questions. This is, again, a large-scale effort, $157 million commitments over 5 years. You might say, well, that doesn't seem huge. We'll talk in a little bit more detail in a minute about what this means for particular organizations. But I would emphasize that this is meant to be leveraging or infrastructure funding. As you heard from Steve earlier and Julie just a minute ago, this is not the only potential source of funding for community-based efforts. A number of foundations, such as the Robert Wood Johnson Foundation, some of the foundations in California, many others are moving in this direction just because the potential for really improving population health through linking healthcare reform to better access to social and community services now seems within reach and seems like holds the promise for a lot more improvement. So now is the time to look into avenues like this one, perhaps leveraged with other private foundation support, private support, as well as local and state government support. As you've heard, not surprisingly, the health impact that is expected to occur here is in areas that contribute to population health gaps, particularly for vulnerable populations, and that have been shown through increasing evidence to be responsive to social and community interventions that can have an impact on hospital use and healthcare costs. The part of this effort is intended to address and evaluate whether taking steps to address these social needs of beneficiaries through community-based resource enhancements can impact costs, inpatient and outpatient healthcare utilization, very much as Julie was just describing. What is the impact on hospitalization and improving other aspects of care? So this is something that CMS is really committed to, and if you're able to respond quickly to these timely applications, is an important source of complementary support to the goals of ACO. So Steve, maybe you can spend a few minutes on how these awards are intended to work.
Sure. Very briefly, if we go to the next slide and it goes into some of the details there, I just want, in the interest of time, highlight maybe that third bullet there and the fifth bullet. But basically, these are going to be designed to really focus on community dwelling beneficiaries and who screen positive for these unmet health-related social needs, and they're going to be potentially randomized into an intervention group to community service providers versus how they're currently getting those needs addressed or not addressed, as the case might be. And again, as we talked about earlier, and Julie mentioned Hennepin, and I mentioned in terms of this bridge organization, that you have to identify this bridge or integrator organization that's expected to partner. And here is the important thing: at least one state Medicaid agency, and then clinical delivery sites, at least one of either a hospital, a provider or practice that furnishes primary care, or a provider of behavioral health. So this is really good because they're going to look at a variety of things. You don't have to have all three of those, but you have to partner with at least one of those indicated there. And then the next slide, and then we'll be going to questions in terms of how they're going to allocate the money through these three tracks. And when you apply, you can indicate which track you're interested in. So track 1, they'll have 12 of those, and they'll get $1 million per awardee. And that really is focusing on beneficiary awareness of available services. So through disseminating information and referral. So nothing more than that, just trying to assess whatever you're currently doing. If you can up kind of the awareness through various efforts, they want to take a look at that. In track 2, if that's of interest, the emphasis is on navigation services. A little bit more money per awardee, $2.57 million there. Provide community service navigation, again targeted to high risk. So this means you have to have some of those data analytics to identify the high-risk beneficiaries. And the third track will be 20, actually, organizations with $4.51 million. And this is the alignment thing that, again, Julie talked about in terms of Hennepin, how they align those 4 entities and with the payment model and so forth. So this is going to encourage that kind of alignment, so to ensure that these services are available and responsive. So basically, that's the information, and again, their website will have even further details. So Mark, turn it back to you. We're open for Q&A.
Steve, thanks for the overview, and we do have a number of good questions. Unfortunately, not time for too many since this has been such a packed webinar, but really a question for both of you. Maybe we could start with Julie on this. If you look at some of the interventions that are taking place in these accountable health community efforts, Julie, yours, and the ones that Steve summarized, some of these, at least, are activities that many ACOs within their healthcare organization, as opposed to community organization, are trying to undertake, such as steps towards ambulatory ICUs, more intensive support services for high-risk patients, or use of community health workers. When do you know, should it be an activity undertaken by your healthcare organization itself? When is it worth it to go that extra effort to coordinate and get support at the community level?
So the question is, when does our organization take it on versus asking the community to? Yeah. So we do have a couple of contracts. We've got a ED, we call it an ED InReach project, where we're targeting intensive case management services to individuals who are high utilizers of the ED, and then also an employment program that is helping people who have behavioral health conditions find employment. And both of those are organizations outside of Hennepin Health, and it's been I think the decision was made because we found that finding organizations who are already doing this work and are already experts at doing it and know how to do it, rather than recreating the wheel in those services, are two examples of where we just decided that it would be good to involve the community.
Yeah. Steve, any thoughts?
Yeah, I think obviously very community by community, but I think it gets to the tipping point where you recognize you have some strong partners, and the payment models across these various sectors are moving in this direction. And then it's a matter of the leadership of your ACO or your health system, if you're embedded within that, and you're seeing that, look, this is the way payment's going to be going. We have to reach out to these other partners. We have to extend it beyond our four walls. That you go for it. You build those partnerships and develop those relationships. And I think that's occurring, Mark, at a varying rate across the country, but I think directionally more and more of that we're going to see.
Yeah. Again, wish we had more time for questions, but this is in the same category of, boy, this seems like the right overall direction, but a lot of challenges involved. Where's the best place to start? I guess that answer is going to vary by community too, but if you were just getting going on these efforts, if you're a physician group or a hospital-based system that's got an ACO but hasn't really moved in the community level, where would you start? Is it around behavioral interventions? Is it around housing? Is it around what you were calling an ambulatory ICU, which I assume is different than just the wires and intubation equipment in a typical hospital ICU, but intense targeted services at home? Is it around basic data and some analytics to help you target who gets these extra services? What's the best way to get going?
I think it's running some data and looking at your population and what you think are the best opportunities for your system. And so I would say that there are definitely things that we just do better than other things, so that would be a quicker, easier win. And so I think getting people involved in an area where the staff feel a lot of pain or really don't feel like they can impact. Housing was really important for us because we found that providers were never even asking about housing in a really unstably housed population, and it was because they just didn't have any hope that they could make a change, and it was such a huge barrier to health that they just stopped asking. And so for us, starting with housing made a lot of sense because we did have that partner, with our housing and homeless initiatives area, but also just to start to build that capacity and in being able to solve some of that. Went a long way, I think, in getting people motivated to continue.
Yeah, that combined with targeting, yeah.
Yeah, I would just add quickly, Mark, begin with your own data, community health needs assessment, and so forth, and then identify, what's really important in terms of the majority of patients that you're seeing and what the needs are in the community, and then to assess your own comparative advantage of what you can bring to the table versus other partners in the community, and try to find answers to two questions, really. Where do you want to play, and how do you want to win? we don't have time to unpack that or go into detail, but you want to ask of the data really, what does this suggest for us to be successful, and what conditions and partnerships make sense for us? In Hennepin, it was with the housing. In other areas, it may be the behavioral health providers or the local school system, and that's where the variance will come.
Well, Steve, Julie, I want to thank both of you for packing so much in to an hour. There are a lot of ways to spend an hour. I can't think of any where the potential payoff is as big as really trying to move practically and meaningfully into these non-medical, community-based areas for potentially impacting population health. It's hard, but really appreciate all the insights that you all have provided to show how it is doable. So we'll be coming back to this important topic in the future. We are at the top of the hour now. Just a few brief announcements before we wrap up. As always, if you have any questions for us at the ACLC, please get in touch with us about activities, et cetera, et cetera. We are having a upcoming brief on Medicare Shared Savings Program ACOs around financial savings and more, reviewing some of the results so far and what's happening next. So look for an announcement or look for that brief being released soon. Also, next Wednesday, so just a week from now, we're going to host a webinar on the new Masters of Science in Integrated Healthcare Management, a recently designed degree offered by WGU, which is our academic partner in this effort. WGU, for those of you who don't know, is one of the nation's leading providers of online educational services. Very high success rates, very efficient, kind of designed for the web-based era, supplemented by personal support. It can be tied to the specific educational needs of an individual or their organization. If you are an ACLC member, you are eligible for a tuition scholarship, or your employees are. So if you're interested in some targeted and relevant training related to integrated healthcare management, I encourage you to join that webinar next week. More announcements coming. Also, for further work in the ACLC, we are now finalizing our rosters for our 7 work groups around the key competency areas. So you should have all received a personal email about this if for some reason you haven't, or if you've got any questions or areas that you'd particularly like to hear about or contribute to, please let us know again at members@accountablecarelc.org. And as always, more information is available on our member portal at the website accountablecarelc.org. Thank you all again for joining us today, and we'll look forward to our next chances to work together on improving accountable care. Take care.